Let's get started on stroke and heart attack and stroke. I'm Peter Thompson, a cardiologist and affiliated with the University of WA and Charles Gardner, and Deputy Director of the Institute. This is what I'm going to be talking about. It's an ugly-looking picture which shows that the build-up of cholesterol over the years occurs in the wall of the artery, and then suddenly, without any warning, apparently, the cholesterol plaque becomes irregular and angry and ruptures and allows this clot to form, and that causes a coronary thrombosis, which is a thrombosis which can cause either a heart attack or a stroke. So it's a very serious challenge, and it happens to too many people in Australia still. However, the news in some ways is good. This is the last century of the incidence of heart attack around Australia, and you see it steadily increased with the war years, and then in 1967 something happened, and we're not quite sure what, but the epidemic of coronary heart disease started to turn around, and you can see that it has continued to improve, and that's a huge success story. The Heart Foundation is very proud of that because they started about that time up here, and it's a great success story, but there are a few worries about it. It's not completely solved yet. The other good news is that if you had a heart attack 25, 30 years ago, your risk of dying in the first week or two was 13%. With the various treatments and investigations and improvements in clot-dissolving agents and cholesterol-controlling agents, the risk of dying from a heart attack in the first month or so is now 4% compared with 13%. So that's really pretty dramatic, and we've been involved with many of these trials along the way that have led to that improvement. Perth, Western Australia, is quite unique. It's one of the only communities in the world where we can track the outcome of people who've been in the hospital and followed up for 20, 30, even 40 years. And here's a graph showing the people who had their heart attack in the 80s compared with the late 80s, early 90s versus the 90s, and they're followed for 12 years. The green was the worst and the blue is the better. There's been a steady improvement, and this data is quite unique. It was published in the British Medical Journal. It's one of the few communities in the world where this data is available, and the news is good. But when you look at the Mediterranean countries, we're not as good as they are. Admittedly, Eastern Europe is still in a terrible state. New Zealand is actually catching up. This is a few years ago. New Zealand is improving, but Australia, we can't relax and say that the coronary heart disease epidemic or the cardiovascular disease epidemic is anywhere near control, because we're just sitting in the middle. And the other nagging worry is that those trends for hospital admissions with heart attack, they've been coming down, sure, but they're just starting to flatten out. And there's just a concern that the improvements which we've had in cholesterol control, smoking control, and improved exercise capacity and lifestyle in Australia might be turning around with the substitution of fatty and carbohydrate diets and obesity and the diabetes. So this is a troubling trend, that flattening. It's not looking as good as it should. This is what happens to your coronary arteries as you grow up. When you're born, they're smooth and thin and slick, and the blood just bounces straight past, and there's no obstruction at all. As you start to get older, the wall starts to thicken up a little bit, and then in the 30s, even without you realising it, there's the gradual build-up of little cholesterol plaques, which you can't see, but gradually that builds up and up and up, and the cholesterol patches start to get enlarged and gradually build up to the point where they can obstruct the artery, and then they develop that roughening on the surface, which was the very first slide I showed you, and that is then what can cause a heart attack or a stroke. So we're all at risk of this, but the good news is that we can do something about that. I'll just take you through the cholesterol and blood fat story. If you go to a doctor and get a blood test for a cholesterol, you get the total cholesterol, the HDL cholesterol, the LDL cholesterol and triglyceride levels. And in summary, the total cholesterol, a lot of women get very concerned because their cholesterol comes back at 6.5, but actually it might be largely composed of the good cholesterol with the high HDL level, particularly in premenopausal females. The HDL levels are quite high, so that's good for younger women, but it can throw out the total cholesterol measurement. So you have to look at the blood test result and look to the good cholesterol, which is the HDL, and the bad cholesterol, which is the LDL. H for happy, L for lousy, good and bad. This is how it works. The LDL burrows into the wall of the artery. At the same time, the HDL tries to lift the cholesterol out of the wall of the artery, take it back to the liver and deposit it and get rid of it. So it's a constant battle between those two. The way we tackle it, and it's an area that I'm very actively involved in the Perkins, on the clinical trial side, this is what you have to do a clinical trial. It's not a simple process. Firstly, you have to have a lot of preliminary data to say that the idea is good and it's going to work, or it may have a chance of working. And secondly, you have to prove, of course, that the answer is not known. There's no point in doing a trial if you already know the answer. And then you have to write a protocol, and the standard protocol that's written these days is a double-blind trial where patients are randomly allocated, and you don't know, the patient doesn't know, nobody knows what group they're in until the results are analysed. You're not allowed to peak along the way through. If you peak, it biases the answer. If you spent 10 years of your life developing a new drug which you want to trial, you're naturally going to be favouring that being a success. So you have to keep the trial blinded all the way through, and you have to estimate very accurately the sample size. It might be only 100 patients required to answer the question, or it might be 1,000, or in some of the big trials these days it might be over 10,000. So you have to examine the sample size very, very carefully, and because you're not allowed to peak on the way through, when you get to 2 years, 3 years, 4 years down the track and you open the results and your sample size was too small, it's a very disappointing miscalculation. Then you have to check that it's ethical. You don't want to take advantage of patients. On the other hand, we're constantly welcoming patients to clinical trials so that they're doing their bit for the advancement of medical science, but we don't want to take advantage of the fact that it's a doctor and a patient talking to each other. You have to prove that it's scientifically valid, and all of that then goes to a series of ethical and review processes. There's a governance process which is to protect the institution and make sure all the insurances and everything are in place. Then during the course of the trial, we have to make sure that all the data is being collected properly and there's no hiding of the data or miscalculation of the data. Then you have to analyse the results and publish. And because this is such a complex process, it can take quite a few years, and often the result will be negative. And I'll show you a couple of results which, after 5 years of very hard work and many, literally millions of dollars, the results were negative. So this is how we analyse data from multiple clinical trials. It's a technique called meta-analysis. When you put all the data together in the whole 170,000 patients in 26 randomised trials with cholesterol lowering or LDL lowering, that's the result, that if you lowered LDL cholesterol by 2 to 3 millimoles, that would reduce heart attack or stroke risk by 40 to 50%. It can be achieved, and it's a very dramatic result. And this is how we do it with this so-called meta-analysis. I won't speak of the details. I'll go through and take you through and show you that when you lump together all the results, you find that on one side, if it goes to the left here, statins better, that means you've got a result in favour of statins. If it goes to that side, it means that the placebo was better. In other words, the statin was useless or damaging. So when you see a result like this with coronary heart disease, 25% improvement, other cardiac disease about 20% improvement, death improved by 15%, these are pretty striking results. And they're the result of a lot of dedication, a lot of trials, a huge amount of work, patients often in these trials for 5 years, a lot of input and contribution by patients to these results. And importantly, see here, no signal that statins used in these large trials cause any adverse effects like cancer. But I'll just take you through some of this just to indicate that it's been a very conscientious evaluation of the statin drugs. The Heart Foundation's come to the conclusion that there's no evidence that statins cause cancer. And here's the blow-up of the cancer data, both men and women, right on the line, no effect one way or the other. Not bad, not good. So no adverse effect from cancer or no benefit, no clear-cut benefit on cancer. But you see the huge numbers of patients that have been in these trials. Then there's been the concern, if you take a statin, and lots of people in this room will already be taking a statin, does it damage your memory? There's some concern about that, but particularly it's been played up, overblown, exaggerated, because everybody worries about it. This is a book that this guy wrote. It's become a bestseller. It's one of the best-selling books in Amazon. But the FDA weighed into this a few years ago. They did say, just be a little bit careful. We can't brush it aside. But actually, the benefits on preventing stroke and heart attack far, far, far outweigh the possibility of cognitive dysfunction, memory problems. Muscle damage, it's true, muscle damage can occur with statins, but it's very rare, 1 in 10,000 or less. And, but muscle symptoms, getting sore, playing golf, walking, gardening, getting sore in the muscles, it is more frequent when you're on a statin, so that can't be denied. The only thing that's got scientific, valid evidence that is a concern with statins is the diabetes story. If you add up all the statin trials, it does cause a touch of diabetes in some people, but you have to have 255 patients taking statins for 4 years to get 1 extra case of diabetes. And if that patient does develop diabetes, the best treatment for them is a statin. So, you know, it's a bit of a beat up. And when you go to statins and diabetes on Google, it's full of lawyers in the US drumming up business. So, you know, we're going to sue the Lipitor manufacturers because it's such a terrible story. Well, it's true, but it's not so terrible. And then, after all that work, all those trials, this program came up on ABC. And if I were Mr. Abbott, I would say, don't go on to Catalyst, don't worry about Q&A, don't look at Catalyst. They got these fringe opinion experts, and Norman Swan a week later showed how shallow their opinions were. They were all promoting their own books and so on, but they didn't say that on their show. And then the ABC refused to retract, same as the recent Q&A story. But the worry was that here's the prescribing of anti-indigestion pills, Somac and so on, and here's the effect of the Catalyst program on prescribing of patients turning up to have their pills prescribed or dispensed, following the Catalyst program, a decline. And here's the number of people who discontinued. Suddenly it goes up after that Catalyst program. 4,000 fewer dispensings, affecting 60,000 people, with an estimate that this could affect the heart attack and stroke risk and causing an increased number of heart attacks and strokes by about 1,000 to 5,000. Scandalous result, and the ABC has refused to retract. So it's pretty disappointing when the clinical trial process is very, very thorough, and a lot of patients have put their time and effort into it, and this is the result we get. So it's very disappointing. So let's have a look at the other approaches. Statins have been a major advance. We have to be very careful looking at the side effects and still keep a close watching brief, but at least on the major issues they seem to be pretty clear. What comes after statins? There's a new group of drugs called these PCSK9 inhibitors. I won't take you through it in detail, but statins are pretty amazing. They can lower cholesterol dramatically. If you add one of these new drugs to a patient who's taking a statin, you can get a further 50% reduction with these PCSK9 inhibitors. So where that will lead us, it's certainly going to lead to greater benefits on LDL. Whether it's going to lead to an improvement in outcomes and even a regression of atherosclerosis, we still don't know. But we're doing trials on this at the moment. Here's one drug that's being done at Royal Perth Hospital. We're doing two here at the Heart Research Institute at Perkins. These are fancy names, but they're very big trials, and we're collaborating on an international effort to see what happens if you take a patient who's got a lowish LDL level with a statin and lower it even dramatically even further. What about raising HDL? If HDL is good, how about a bit more, lifting the HDL level? And you can indeed raise the HDL quite dramatically with this group of drugs, and they can get dramatic improvements in HDL. But when you trial them, something didn't go right. The theory didn't come out right. After 3.5 years and several hundreds of millions of dollars in this trial, we didn't spend that money all in Perkins, we're part of the collaborative effort, but no result came out. So you can't necessarily assume that because it's a good idea, let's raise the HDL and that will necessarily result in a good outcome. You have to do the trial, and it's hard work. Triglycerides are the free-floating fat. They're not quite cholesterol. They're more like pure fat, like the fat that settles on the top of a soup when you cool it off. And they've been very controversial. We don't really know if triglycerides make a big difference, but we're investigating it. If you look at triglycerides, the higher the triglyceride level in your blood is, that's bad for you. But when you correct it for age, gender, all sorts of other things, the connection is lost. Whereas with HDL, it's not lost, and with LDL, it's not lost. So this is, higher HDL is good for you, higher LDL is bad for you. Triglycerides appear to be bad for you, but when you correct for everything, it's not so bad. So the drug we know lowers triglyceride is fish oil. Polyunsaturated, omega-3 polyunsaturated fatty acids. But even though it's all over television and that's the thing you have to have and so on and so on and so on, actually the data is not as strong as it should be. And overall, it's not associated with a lower risk. And when they put all this data together on a reasonably large number of trials, it's not as convincing as you would get the impression from reading those ads on TV. And it's been plagued with methodological issues, tepid, uncertain, and conflicting results. A pretty neutral sort of result for those meta-analyses, which, as I showed you, for statins were quite overwhelmingly supportive. And in Australia, this group of experts got together with Professor Paul Nestel. There has been no further evidence to recommend supplementation. It's not going to do you much good. So by all means, you can get your omega-3 fatty acid tablets from the chemist, but whether it's going to do you any good or not remains uncertain. Nevertheless, we haven't closed the door on it. We're still involved in a trial with this super omega-3 fatty acid, and it'll be another couple of years before we know if really getting in and using a very powerful fish oil type derivative is going to make a difference or not. So moving on to the treatment of heart disease, we've been actively involved for a long time in new treatments for heart disease, and coronary stenting has been around. This is while Dick Cheney and George Bush were invading Iraq. He had a bit of coronary trouble and had a stent put in. So it's not a brand new intervention, but when the stent goes in, it gets pushed through the plaque, opens up the blockage, then a balloon is expanded and gets rid of the blockage, or gets the blockage squashed to the edge, and to stop it falling back into the wall of the artery, into the middle of the artery, you put in a stent which looks like this. Here are these very fine mesh stents. Very fine mesh stent expanded on a balloon, and once that stent is in, then you have to use powerful anti-clotting drugs to make sure that it doesn't block up. The standard recommendation is that you have to have very powerful anti-clotting drugs for 12 months. Of course, if you have powerful anti-clotting drugs, you have a risk of bleeding. So the question is it 12 months? Thank you. 12 months the right duration, or should it be longer? So we were actively involved in this trial called dual antiplatelet therapy trial. So that's now evidence that perhaps you have to continue for longer, because if you have the placebo versus the dual antiplatelet therapy continued, it's better. And here's a newer agent compared with the older agents. The newer agents are better, so we've been involved in that project as well. But the final thing I want to talk about is what happens to a cholesterol plaque when it becomes unstable. What makes it become unstable? How come somebody can have cholesterol build up in their arteries for 30, 40 years, perfectly comfortable, not even having any angina or any trouble at all, even their cholesterol might be well controlled, and then suddenly one day they're in the coronary care unit with a heart attack or worse? I showed you what happens with the cause of it, but we don't know why. Here's an two adjacent arteries in the one patient right next door to each other. This one here is perfectly stable, a bit thickened, a little bit of cholesterol, some calcium, but blood's flowing. It might be narrowed, but blood's still flowing through it. Compared with this one here, where the cholesterol is fragmented. And if you look closely, anybody who has looked down a microscope, these are blood cells, inflammation blood cells, showing that this plaque is full of cholesterol in an abnormal form and very inflamed. That's the one that's going to cause a coronary thrombosis, and that's the one that's not. How we distinguish those, of course, is a big challenge. This is how cholesterol looks under the electron microscope when it's in that abnormal form. It gets spiky and quite ugly. We've been working on a drug called colchicine, which is actually a standard drug used for gout. And it's a very potent anti-inflammatory drug. And we hypothesised that maybe that would work for these unstable plaques. And in fact, it does. We've got a nice publication in this journal where here's the placebo-treated patients and here's the colchicine-treated patients. So we've now designed a larger study, and this interesting observation has triggered off 5 other studies around the world. There's two going on in Canada, one in Wales, one in the US, and there's a great deal of interest from this quite innovative work which we were able to be, well, we did. It was good. How to assess risk. One of the things that we're also involved in is how to pick up those ugly-looking plaques early on, rather than waiting for the sudden coronary event, which can be fatal. And there's a whole lot of investigations going on, but one of the things you might see in your tour through the Perkins is up on the 3rd floor. there is space for a big imaging centre which will be doing all of this sort of stuff, looking for atherosclerosis and picking it up early. Here's one of them, coronary CT scanning. Here's a coronary artery without any calcium in it. Here's a coronary artery clogged with calcium. That patient has got much more risk of heart attack than that patient. And the more advanced on that is having a CT angiogram rather than waiting for the calcium to form in the artery, just picking up very, very early atherosclerotic plaque. That can be done with these very advanced CT techniques. And sometimes you don't even have to go to catheterisation. Here's CT angiogram with this picture showing up a block, and here it is confirmed on catheterisation. So the future, what we're about, is trying to focus in on atherosclerosis, and we need to keep developing reliable methods of identifying high risk. We need even more potent methods of cholesterol reduction, and the prospect, the exciting possibility that the plaques of cholesterol could be actually regressed and reduced with these newer drugs is very exciting. We have to wait and see the outcome. They might be causing some, they might have a sting in the tail where they cause some unexpected outcome, but let's wait and see. You have to do the work and do the trials to find out. Of course, the challenge, one major challenge is how to prevent thrombosis on the stents or on those plaques without causing excess bleeding, and that's a big challenge. And then the inflammatory process I showed you with our colchicine work, it's very exciting, and how to control that, and is colchicine the best drug? Is that the way to go, or should we be looking elsewhere? And eventually, that will lead to a continuing improvement in heart attack and stroke in Australia and in Western Australia. So that's what we're about. Thanks very much.